Okay, so this is part 3 of lecture 2, picking up with where I left off before, and now we're moving into the safety assessment. Basically, safety assessment means we're examining for risks of suicide or homicide with our clients. So I'm focusing primarily on risks for suicide when I go through these particular slides, but you can also consider these same factors comparatively for somebody who is experiencing thoughts of homicide as well. There's very little that you change when you are going through the process of examining either suicide or homicide. So just keep that in mind as I go through these couple of slides here. First and foremost, we want to be able to understand a particular risk indicator. So these are basically predictors that may show signs of being alert for to possible attempts or thoughts of suicide with a client who you are beginning treatment with. So keep in mind that this slide is not going through the actual factors to examine if somebody is having current thoughts of suicide. That's going to come up in the next slide. These are just general predictors to keep in mind. Things like history of prior attempts. It's one of the greatest predictors of possibly engaging in further attempts. Success of suicide by a role model or someone close to the individual could also be a predictor. Loss of a close individual in that person's life, major physical and physiological or psychological stressors. So if they're just diagnosed with a terminal disease, that type of shock can be something that may also be a possible risk factor for suicidal thoughts. Feelings of hopelessness, impulsivity, or sudden mood changes. So these are all kind of characteristic features or historical things that may increase somebody's likelihood of having suicidal or homicidal thoughts. The greatest risk for completed suicide, so people who are actually committing suicide and killing themselves, demographically is among older white men and homosexuals. So, of course, that doesn't mean that everybody in that category are going to be those who actually are engaging in full suicide, but this is just another risk factor to keep in mind that that particular population has the highest risk chances overall. So, moving forward, let's see if I can get these slides to move. There we go. So when we're actually thinking about assessing suicidal risk for your client, this slide I've taken from National Suicide Prevention Lifeline goes through 4 particular factors to keep in mind. Basically, what we see here is the desire, so reasons why someone may be at a place in their life where they may be feeling this way. Desire, capability, or what we would say means, the means to kill themselves, the intent or the plan to kill themselves, as well as, and this one is also very important to keep in mind, the buffers. What's stopping them from doing that? You know, they may have very strong desires or to want to end their own life, but maybe there's something in their life that's stopping them. These 4 components are critical when you are creating or when you are assessing somebody's degree of risk for ending their own life. And you want to consider all 4 of these topic areas. So I want you to become familiar with this slide here and the themes that are presented in this slide. But more importantly, when it comes to a clinical review during your assessment is this next slide here, which is the suicide ladder. Basically, you go through one from the next, but the length of time that you spend doing the suicide assessment will depend on the answers that you get. Of course, before doing the suicide ladder screening for suicide, it is very important that you discuss the limits of confidentiality because somebody who is reporting is significant difficulties in these 4 areas, right? They have a desire, they have the means, they have a plan, and there's nothing holding them back. There are no buffers. Those 4 components are what lead us to decide whether or not we need to either breach this person's confidentiality to ensure their safety. So we have to make sure to mention that first before we go any further. And when you go into this topic area, find some way of normalizing it first or transitioning into it. It could be as simple as saying, hey, we're going to talk about something uncomfortable right now. So just let me know if this is tough and we can slow it down or come back to this later. You do want to ask these questions, but make sure you give them the chance to really express their comfort first. Ask them then if they've had any thoughts of self-harm. If they say yes, ask them if they've had any attempts in the past where they've tried to hurt themselves, they have hurt themselves, or have tried to end their life. Get the full detailed story of what happened and how this resolved. How they felt about it too, how they feel about it today. Ask them then if they have any current feelings of wanting to hurt themselves or in their life, and if so, it's really important to stop and slow down at this point, because if they're sharing this information with you, that's a pretty good sign that they want somebody to share this information with. And sharing this information is one of the best ways to help them feel better. So we want to give them time, normalize it, empathize with whatever reasons they have for wanting to or thinking about ending their life or ending somebody else's life. Ask them if they have a current plan. If so, do they have means? Do they have they made any sort of preparations? What's holding them back? Remember, that's the other part of this slide here too, the buffers. What is it, what reason do they have for not wanting to end their life right now? If they can't name any reasons, if they have plan, if they have intent and means, and there's nothing stopping them, we have to consider how we may need to find support for them, or if we have to breach their confidentiality. One way that we can do this a little bit easier is by asking them if there's anyone that they're comfortable with us contacting with and that they can stay in contact with them. This could be a family member, a close friend, somebody who we can guarantee and confirm and document. Remember, documentation is the key here. Whenever you see a significant risk, we have to document who you contacted, permissions or non-permissions to do so, be it a friend, family, or ultimately 911 if we can't get anybody else available to help this person. Because remember, we're doing this if they are telling us they are actively suicidal. They have plans. They're telling you what they're going to do, when they're going to do it, how they're going to do it. They are considered actively suicidal at this point, and we have to have some kind of follow-up plan. Try to have a client there while you're making the call. Even though we don't need their permission to do this, it'll be a lot better for them to be present with whoever you're calling to get their buy-in for this the best we can so you can continue treatment after this is over. You want to follow up with the client the next day. Make sure, and this is an important thing that I've missed in the past, so make note of this, that if they are going in for a hospital visit, if you have to call 911, try to get a release signed ahead of time so that you can contact the hospital and get an update about how your client is doing. Otherwise, you'll be stuck, because if they're in the hospital and you don't have a release form, then the hospital can't tell you anything about them being there. You want to be able to get that follow-up plan done. Once you've got the follow-up plan done and the crisis has been resolved, that's a really good time to talk more about whatever lethal means that they had told you they have, whether there's guns in their house or they have a pill bottle of some sort that they're not using but just kind of saving for moments like this. It's good to be able to discuss that with them in the future. Maybe get somebody else for accountability to help them get rid of or hold on to whatever means they have that they could end their lives with, if possible. Okay, so now I'm going to talk about something a little bit different, moving on with a very important diagnostic issue. There's something called post-acute withdrawal syndrome, or syndrome, I should say, but there are particular symptoms as well that we want to talk about. There are other words for this: protracted withdrawal or the wall stage, depending on how you've heard this in the recovery literature in the past. This is not an official diagnosis in the DSM, but it is critical to understand that this is a thing that happens for many people, especially in their first year of recovery. Some of the symptoms can include anhedonia, which is the inability to experience or feel pleasure, significant anxiety, disturbing dreams, heightened cravings, sleep difficulties, eating disturbances, difficulty with concentration, even memory I've heard with many people, and a lot more irritability. Generally, these symptoms sneak up on people gradually during the first 2 months of their recovery. They may not even notice it's happening. Many of them may assume that they have depression, but this is different than depression. This is a direct effect of how the brain adapts to the first year of abstinence from a substance that someone's been exposing to their brain in heavy amounts for a long extended period of time. These symptoms are expected to gradually improve over time so long as this person is committed to their recovery program. Many people may give up on recovery when they get hit with post-acute withdrawal symptoms because they think it's not working. There's just no other way. They'll lose hope in their recovery. But that's why this is so critical to share with them that this syndrome is out there, because it's real and it's temporary. If they keep it up, if they keep abstinent, they can get through this. So the reading, Miller and Harris, is a critical read because this publication went through the theoretical underpinnings of PAWS, post-acute withdrawal syndrome, and basically statistically validated it. There was another word for it in this research, which is protracted alcohol withdrawal syndrome, which is the same concept, really, just different wording for alcohol. PAWS was based on Gorski's original model of recovery, which included what he called 37 steps or signs, which were warning signs of relapse. So Miller and Harris decided, let's validate this. Let's really go through, let's collect a sample of people and find out whether this is an actual syndrome that's happening with people based on these 37 signs that Gorski proposed. So they developed an assessment based on these 37 steps or signs, and they called it Assessment of Warning Signs for Relapse, or AWARE. They used all 37 and they put them into a 7-point Likert type scale format. There was previous research that showed that this was a reasonably good predictor of relapse, and so basically Miller and Harris wanted to perfect this and really validate this as a construct. So they used the AWARE and they surveyed 122 alcoholics in recovery over 12 months' time. They gave this survey 7 times over those 12 months. And the reason is because they wanted to see if high scores on the AWARE could predict slips or relapses during their 12 months of recovery. Slip was basically any use of alcohol, where relapse was considered heavy drinking. So go back to lecture 1 for the definition of heavy drinking. The study only focused on how well these items could predict slips or relapses, but the real thing that they were going for here is understanding, could they create a construct? A construct is basically anything that we can call a syndrome, like depression, right? That is definable and consistent, right? It's not just some kind of random label that we just made up. We want to see whether or not these 37 symptoms come together to create a consistent thematic pattern that more than one person is going to possibly experience. So that's the statistical part of this. Of course, this isn't a statistical class, but it's important to understand the importance overall diagnostically in doing something like this. So they performed a factor analysis, and they were successfully able to create one single cohesive factor using these items. They had to take out 9 items that didn't really fit with the overall theme, which left them with 28 item survey, which is actually really good. This really does demonstrate that using these items, although not all the items mattered, but these 28 were able to consistently predict whether or not someone was going to have a lapse or relapse. Furthermore, it shows that this is in fact a syndrome that many people do report experiencing. Convergent validity basically showed that this scale that they created correlated highly with other scales that measured things like relapse risk, depression, emotional distress, and lack of purpose, which fits very well with the symptoms we talked about already when it comes to PAWS. So that's a very important study to keep in mind when we think about diagnostically what someone's going through during relapse or during the first year of recovery. All right, so this is going to pertain a lot to the lecture response for this week. I want you to watch this video, Katie's story, and identify a couple factors, and then watch the follow-up video and identify what's changed. So I'll show you another slide in just a second, but just so you know, Katie's story is on Module 2 for week 2. So go to the actual module on e-learning to watch this video because it doesn't really work very well with face capture like this. Then you need to record your lecture responses and submit that with Dropbox. Basically, what I want for a lecture response is identify 3 diagnostic factors from that Katie's video. They can be anything. I want just 3 particular things based on the content that we talked about in these first 2 lectures. So strengths, resources, what stage of change she may be at. Then, based on video 2, identify 2 factors that changed between the first video and the second video. Let me know if you have any questions about that when you're doing this lecture response. And then very simply explain in your own words why that PAWS syndrome that we were talking about can be very meaningful or important for a client and the therapist when treating someone who may have a co-occurring disorder. So put that in your own words, how that syndrome could be very important diagnostically and for the client to understand. If they think they have depression, right? but they're only in their first year of recovery. What would you tell them, and how could that be very important to the client? So these are the 3 parts for the lecture response for this week. You can turn them in once you've watched all 3 of these lectures, which you should be able to do now.